actually a native Richmonder on my fourth career. I grew up here and went off to college and law school and was a lawyer in DC for a few years, and then decided to come back home and start over. So I got into the nonprofit space working on with homelessness, and then I worked at William Byrd Community House, which I have a story about design because it was a poverty prevention organization, and the space just looked like poverty. So I went over to LaDiff and asked them to get us some nice furniture, and it worked. To your point, it just changed the whole energy. So I worked there for a while. Then I went back to the Red Cross as a CEO for the state. Then I was at the city with community wealth building, right? And I left the city 2 years ago to take this job as the CEO of the Richmond Memorial Health Foundation. That's my journey.
Could you talk briefly about what that organization does?
Sure. It's a private foundation that focuses on fostering racial and health equity in this region. We're private, so we give away around $7 billion or so every year to organizations that are on that journey in this community addressing the social determinants of health. So that's our work.
Kathryn?
It's hard for me to be concise. It's okay. Like you but maybe double. I've had a lot of careers. Initially I joined the Peace Corps out of college because I had been a French major because pre-med did not work out for me. And I wanted to go to Mali and West Africa, which was a country that I had studied as part of my French degree. So that's what I did, and that just reinforced the worldview that I got from my mother, that without community, we are nothing. So then I moved back to Chicago because I married a Chicagoan, and what degree do you get in this to do this, community building work? And I got a master's degree in urban planning and policy. And then I started working at a sort of interface. And Mali was a Muslim country, and so I was very, immersed in that culture, and still have very close ties to my family in Mali. And then I worked for a Jewish organization in Chicago, and as a Catholic, and did community, development, kind of capacity building, and also organizing, and then involving foundations in that work, so they would support more grassroots community focused work. And then I became pregnant with my first child, and so that's how I ended up in the midwifery space. Because I had complications in pregnancy, and then in delivery, and that were completely unexpected. And they say, trauma is not necessarily what happens, but the difference between what happens in your belief about what should have happened. And my mom and her siblings were born at home, and so having this traumatic birth experience I just couldn't. I was not okay, and then struggling to figure out what to do next and afford childcare. And I was going to do some union organizing, but they didn't pay you anything in those days, and ultimately did a bunch of odd jobs while we even had second, third, and fourth child. And that included ultimately becoming a midwife, because as soon as I saw that, understandably, I was treated a certain way, and then that just continued. And I think the first birth that I attended as a doula and saw the disrespectful care was so intense. I felt like I have to be a midwife and catch all the babies, but then learned that you can't just you can't save every single mom and baby, right? And I ended up getting into lobbying work when I was in Maryland, and so then that's kind of the through work in all of my different. Then I always did the lobbying piece. Had a rural practice in West Virginia. And then moved back closer to home because my parents were getting older, and obviously they were not going to move to Wisconsin. They're going to stay in Virginia. And my lobbying, community organizing landed me on the school board. So I was a public servant for 4 years. And then taking everything I
You want Richmond
learned,
School Board? Or
no,
City?
Chesterfield County, yeah. And so I was a political outsider, and I won a conservative. It was a red seat as a progressive but bridge builder outsider. And then taking all of that, then I had to move even closer to home. So then I moved to James City County, and it's like when I saw that I was job hunting, really looking for this special thing. And my husband was like, "We can't put any more down on the credit card. You just have to take anything." But I was like, "No, I have to." When the job popped up at Virginia Interfaith, so much of having learned how to move the system, on a conservative school board, we passed a systemic racism is a real thing statement, right? I mean, you would think that you could never do that in Chesterfield, but we did. So when the job came open at Virginia Interfaith, I was like, yes!
Found it.
Be the lobbying when I'm 90. And got to go back because they lead a maternal health coalition back into the advocating for midwives space, which is just I really do believe peace on earth begins with birth. So
amazing. Yvonne, tell us a little bit about you.
You guys are so interesting. Love it. I've pretty much stayed in the same career as a licensed clinical social worker, but I've done a variety of things in that career. Private practice, worked at a community services board, helped open a group home, and worked at a residential treatment center for adolescents. And then through the course of that, most of that is just very siloed work. You're working one-on-one with a person, but I, through many trainings, Bessel van der Kolk really popularized the idea that all emotional things are also carried in the body, and I became really intrigued with that idea. And it felt so true with what I was experiencing with people, and I began developing this vision for a place where people could come and have their whole self recognized, their mental health, their emotional needs, and their physical needs combined. And so I kind of reached the end of my rope with residential treatment work, and decided to start my own little practice. And I just was envisioning a place where maybe 5 people gathered, and we kind of wrapped around patients from a variety of aspects. And that just took on a life of its own. So since I started this practice, Zoe RVA Health, in 2014, it has grown from just me to this, what feels enormous practice with 3 locations. And we now have, I have lost count. I think we have like 35 therapists, 9 nurse practitioners, and then we just opened up a primary care practice that has 3 providers, and looking at growing that. So that's me.
Great.
And I'd love to
so I
talk to
can
you about
recruit, because I passed a bill in January. We did something for the nurse practitioners, nurse midwives, and pediatric nurse practitioners.
Great.
Cool.
Yeah, I love nurse practitioners.
Exciting.
That's fascinating.
Well, what's I think most interesting about this panel is that all 3 of the different backgrounds. So again, somebody who's working in private but trying to get the holistic person, working on policy sides, I think that makes it really interesting to find those connections, to tie the private with the public sector and how those 2 things can support each other. So one of the first questions for the group at large is really understanding and sharing with our audience how the health outcomes are shaped by these economic factors and social factors of where people are and what they can have access to. So curious other ways that we could effectively advance these communications and the partnerships between people. So the policymakers, the educators, the community organizers, how do people find resources to find the care? How do people know when they can go to Zoe Health or what they offer versus other places? How do we bridge?
Well, I think that's the big challenge. feels as though here we are in 2025, and more often than not, you'll hear people say, I don't know how to access resources, and so, it feels like we should have the technology today to make it easier for people to find a match, but it doesn't seem to be happening, and I think the challenge is you're only as lucky as whoever you happen to find, and that person has a lens on the system. Equity would mean people would have all the information or access to it, as opposed to just your case manager. I think that's how I look at it.
Great point.
Yeah.
I mean, we try to have, within all of our providers, a shared community resource page, so anybody looking for anything can point, but for the patients to have that.
Right, yeah.
Yeah, how do they get that? Especially if they don't have insurance, because their insurance company will point them to who they'll pay for.
Exactly.
Not what all's out there.
Yep.
I think you have to find the people that are the connectors, and that's why community health workers, I think that there are certain kinds of people, midwives fall into that role too, that, motivated by, your personal understanding of a situation, you cross class and race and religion just naturally, because you're driven by that experience, and then figuring out how to fund so that you can make those connections happen. Right now, I'm able to pull together a group of midwives and community health workers and doulas, and I was able to interview one of the community health workers who's going to join the group. And we haven't. It's like a type. We've never met. Right? She's from grew up in rural Southwest Virginia, and we're like instant best friends. Right? She just certain are always asking the questions of how do I. But those people don't always get into a room together, and so we just have to get people like you who understand, right? Like, this is how you really build health, and then make sure they're community health worker type folks that are connecting to the community and then connecting back to you, and it's everybody is sharing. I think just certain types of people always cross into different spaces, and like their whole job is how do we all get already I was talking to this student midwife who's in West Virginia right now, and Camarilla and Plateau is this big maternity desert, and she's like, I could move there, and like I'm open, so you just have to get all the people together.
So it's finding out about the services. So it's people getting connected with other people. Can some of you talk a little bit about then that person, their trust and sort of relationships that they're building with the doctors? Is that something, we've heard that as a barrier in terms of they don't always believe that they're going to be listened to, or that they don't feel like they have been, or this doctor isn't talking to that doctor looking at this test. I'm curious, if you got to the right person, you got to the right practice, what are other barriers that sometimes people find in sort of maybe really sharing what's happening with them to get care?
I think Kathryn raised a really excellent point about community health workers. It sort of ties into your question, because people, I'm generalizing, are intimidated by systems.
Yeah.
And in my professional journey, I find that anything that looks like it's from the government or from a system, hospitals, people get nervous, and then they turn to their neighbors and friends to ask for interpretation.
Yeah.
So if we could sort of flip our practice to say, who are the folks that are the influencers in neighborhoods, and doulas, midwives, community health workers, and have them, here's the latest, greatest information, rather than trying to appeal to those of us who run nonprofits or foundations. Let's go to the people and put our energy there so they can translate it and make it accessible for the people that they know. right? I mean, I think that's, well, you guys do this, yeah.
Yeah, and I think one of the things that, was part of the vision for Zoe, RVA Health, was that it started with mental health primarily. And so I was very well aware of how anxious people are, to your point about the trust. Right. And so that is they're most anxious coming from underprivileged places. They don't trust any authority. You're going to take my kids away from me if I tell you, what I'm struggling with over here, So they don't trust authority, but everybody now is having a hard time trusting authority. And it's so anxiety producing to go to a doctor or a mental health worker. And it takes a lot to get there and then develop that trust. And then you've got whoever's at the front desk. How do they treat you? Mm-hmm. And so I think that's one of the things that we're getting more and more feedback since we started the primary care branch of, oh my goodness, if you're opening it up and I know this person here and I know the billing team here, then I can trust that I'm going to go over here and have a good experience. And we've even had one example is a patient of a therapist who had some medical trauma, and was needing to go see a doctor but was afraid to go. And so the therapist was able to just walk across the hall and show all the exam rooms, introduce the doctors and everything. And so then the anxiety goes down and then they're able to open up and get many needs met. And so that's one organization as a community trying to be a resource to the larger community. And how do we have more of those community hubs, I think is, 100%.
Yeah. That's probably why space plays such an important role, because if you don't have that personal interaction with someone that you know, if you have to walk into a space, that space should feel welcoming.
Yes.
And not as institution, because you're already afraid of institutions.
Yes.
So something that, I can calm down, whether it's the color and then the first person you interact with, sets the tone for the rest of the day.
Yes.
Or it could repel someone from the system for months or years.
Yes.
So at least if the environment can be nourishing, then that's
very much.
I think we've heard stories about the acoustics between patient rooms, and so that idea of how much, again, it goes back to that trust of how much am I willing to say and be honest, and you're really only going to get the care you need if you're really sharing what's happening. But understanding the space is creating that privacy barrier that you're not hearing your neighbor's stuff, so then you don't think they hear you. We heard some people talking about, I think it's Whisper AI, but some doctors are using them so that it records the discussion in your appointment, so the doctor can still look at you.
Yes.
Versus I was just at the doctor the other day and they were still back just typing on their keyboard while I was trying to answer kind of really sensitive questions. So that's a technology option to put us back FaceTime while still allowing the doctors to take the notes they need to get paid. Insurance, you don't have your note, then you don't get paid by the insurance company. So those sorts of ways and tools that we can use and providers can use to build the trust, build that relationship with your person.
And if you think of the space from a midwifery perspective, right? Because midwives believe in normal birth, right? Yep. It's normal until it's not normal, right? And it's until proven guilty, where it's kind of the same thing. You have to. In some countries, you actually have to justify why you would use an obstetrician, right? And so if you think about then it's a normal process, and we talk a lot about other normal physiological processes, right? Like going to the bathroom. And then you think about the fact that you're doing this physiological thing that is very equivalent, but in this, sterile looking room surrounded by a ton of people, you're supposed to be in this gown. And so a lot of the things that you try, I think it was when Emma came out that I shared this picture of a friend who has a birth center, and it's bright and airy, and so when you're in early labor, it feels very homey. but also more of this expansive, right? Because you're opening, and then also has this, lovely bathroom that is dark and secluded. So when you're ready to, you have a shift in hormones when you're ready to push the baby out, and you can go, if you want, you can go into this smaller space. But you also might feel safe. You might stay, you might be in the birth pool, you might be in the bed, but really thinking of the design. She's a master of design, of what makes you feel safe, because you're probably not going to be able to go to the bathroom if 4 people are watching you. Midwives always think it's a miracle that our C-section rate isn't even higher than it already is, because it's just not, it's a miracle that it works the way it does with all of that interference. So
it makes me think a little bit too about those other design interventions, but things that relate specific to those cultural items or to the emotional experience of people. So understanding, or talk a little bit about how do you not create a one-size-fits-all when we have, especially here in the US, so many cultures and so many backgrounds and everything that people are bringing to their healthcare experience. How do you facilitate those conversations to understand everybody's perspective? How do those people feel comfortable being a part of that focus group, let's say? Curious how to get them involved within the design process so that, we hear those stories to share.
I know the onus is on us, because we have degrees and we have, read a lot and read the research, and so it creates this power dynamic where when you speak with someone who has lived experience, I'm not sure we're always able to set aside our academic perspective and tune into what they're actually saying. So I think we need to build that muscle just to listen, and even if it's not our own perspectives, like, we're here to serve. So if this person is telling me, I feel more comfortable if the space were laid out this way, or these are too many questions, or then we respond to that. Years ago at the city, we did, this is a little bit off topic, but it was childcare, and there's a need for more childcare opportunities. And so the people at VCU, I think, did some research in neighborhoods to find out what does accessible childcare look like. The research indicates how things should be structured to have a safe environment for children. The response from the community was, somebody next door, or my aunt, or so-and-so down the street. That's the priority, not a place that has trained professionals who know, so I think that was, and there was a lot of tension, because it was like, well, they don't understand. Like, but wait a minute, they just said that that's what they want. But there's a real pushback when we say, well, research doesn't prove that that's going to help children to succeed. Like, you're shaking your head because you know this, right?
Yes, right? I mean, because I was thinking of two things, because like my first time I get to help pay for the bills, because we have a child and I can't afford childcare, was I'll be a nanny, and then we'll build up to having a child care center. And all the licensing regulations, you have to create that research space. And I very quickly decided, I can't do this. There's no way I could possibly do this. And so we found the gray area that, if two friends decide to be nannies together and hang out in a house, technically you're in this gray space. And so that's what I did until I could, get my feet under me.
What a great example of the systemic barriers to just being able to do something as basic as
helping somebody with their kids.
Yes.
But then also the research, because it's, when I, because I struggled with depression with my first, and so the first time that I did group prenatal care, I was like, this is it. Right. This is how we have healthy moms. And I asked around to the policy people, this is before I had really gotten into it, And I was told, well, there's no research that prenatal care, right? And literally, it's a couple months, it's like this year, new groundbreaking group prenatal care is, and then and this just happened like 3 days ago, skin to skin, there's a lot of research, right? And I knew that, right? And then interestingly enough, like 10, 12 years ago, when I was practicing in West Virginia, because in West Virginia, when you're in an area of scarce resources, you have to try the things that aren't researched, right? And so they had brought Dr. Niels Bergman in, and he was a physician, a public health physician in South Africa. And he had, right, because South Africa, if the baby either dies or it's in the skin. And so he was firing everybody, and I was like, finally, they're going to get it. But no, it's now. There's now the Cochrane has done a review, and now we know that it would be unethical, immoral, right? But the research has been there for a long time. It just wasn't the research that the systems found acceptable. Hardcore research, like the baby's in the NICU for 17 hours versus 1.5. They do the intervention, and then the bill that would be for the family, just all,
I think we're going to avoid insurance as a part of this conversation. I think that's a whole other beast that's got a lot of issues in terms of accessibility and payment and affordability and all of that. But I think really focusing on, the community side of it and this education and awareness building, I think is what's important for people to see the organizations here in Virginia that are trying to connect people and trying to help them find the doctor's practices. There's lots that are moving towards that holistic, or there's technology where people are starting to all use like MyChart so that all of your doctors upload to one place. But other examples are that until you get that report, until you understand from your doctor, you look at that list and like, I don't know what any of these, this one's red. Okay, why? So it's again back to, you provide so much information, but how do you actually give the people something they can digest? It's like, give me the cliff notes of what I should really understand. So it's back to the idea of tailoring the conversation, meeting people where they are. So focusing on the things that they can change and what we might want to do versus all this scientific information that you're just like, well, I don't know. So then you get scared of it and you don't want to go take that test, or you don't want to have something else happen. Do any of you have specific questions for each other after we've started talking, or I can go into some other ones that come up? I'll let you all ask some too.
I have a question for you.
Sure.
So, often my big thing is, that you need money to do this policy work, and so many of the funders don't understand, right? They want these big, huge projects with 20, and I've been so impressed by the work that you do, because you really do support these, very grassroots community driven that then lead to health. So was the Richmond Memorial Health Foundation always like that? When did that shift happen? Was it hard to convince people? Because we need more of you and more of your organization, but that's how we're good. Ultimately, we're talking about space. That means, we're gonna have to pay for, right? You don't get a free clinic that looks like this space, right, without resources.
So we're 26 years old, 26, 27, and the Rich Memorial Health Foundation sort of germinated from the Rich Memorial Hospital. So that closed in the late 90s, but it was one of those hospitals that had emphasis on equity and inclusion, integration, all of those. So we, I think, carried that ethos. But you're exactly right. In the beginning, the foundation was designed to provide support to clinics and folks who are specifically dealing with equipment or strategies for the hospital system. So, and I was on the board for years before I resigned and applied for the job. But So I do know the journey. The journey was at a certain point, the trustees were like, the need keeps growing. What's upstream? You know, maybe we're not effective if we're just giving out millions every year and people keep saying nothing's changing. So that's when it began to shift. And it was a process to bring in people from other places around the country, to look at other foundations and to find what we were missing. And it was this health equity, racial justice, you know, that was the terminology that we began to explore. And most trustees went along with this shift. Maybe a couple said this, I didn't sign up for this, it feels too maybe political, I don't know what the word, you know, but we're a private foundation, so we're in a unique position to say, what about policies? You know, maybe we should fund the organizations that are addressing the policy shift. And a lot of energy around that is still prevalent and growing. We brought in, we had some community leaders to give us advice about how to change, which hadn't been done before, like the foundation to say, you know, what should we do differently? And they're the ones that said, drill down hard on supporting policy organizations and give multi-year funding, involve the community in the discussion, look at Black and brown entities that are trying to break into the space. So it was really, our shift was community led, but you know, I love the trustees that we have because they said, okay, let's do it. And we actually had a conversation at a retreat about a year ago about, should we just spend all our money? You know, are we part of the problem? Foundations grow assets. So it seems counterintuitive if the need is great. So, you know, should we just give it all away quickly? But then we decided, no, because things will keep evolving. So someone needs to be around for what's going to be the issue 20 years from now. And we hope that our focus on policy will lead to better outcomes, which means fewer nonprofits, not to punish them, but just we're smarter and we can be more strategic in how we address it. So that's been the journey. And other foundations are, I think we're leaders in a way in Richmond, but we're all working together now in the foundation community.
Yeah, and I think I heard you speak at something that Warren Whitney put on.
Oh yeah, recently, yeah. Mm-hmm.
Is it Richmond Rising or something
RVA
like that?
Rising.
RVA Rising, and
yeah.
So you're not siloed.
No, we're not siloed.
You're really
Yes.
collaborating with
Right.
other
Yep.
folks to try to
Yep.
raise everybody
Yep.
up.
The
Yeah,
Chamber,
which is,
United Way. This is a great moment in our community. We have to get this right. Even a conversation like this, we need to just recognize how do we connect to, I think it's the others, or people who are, that we need to blur that line about who we're trying to help and how we can be equitable. I know equity has become controversial, but certain people need more. And so that shouldn't be a dirty word, you know. I don't need as much as somebody else across town, so I'll gladly hope that more money goes to help them so they can get to the middle class. Why is that so controversial to say we want more people in the middle class? So we'll have fewer needs for all these programs.
All right, Kathryn, I'm going to ask you one. You talked a little bit about this, but the idea of kind of what's happening abroad and then like what's happening here. I'm really curious to hear some more trends or things that we can learn as you were describing when you were traveling overseas. What are things that they do when they don't have a lot that could be implemented here, could provide more steps forward?
Well, having been abroad, I guess is how I knew about community health workers. And I think it was funny. It was not funny. It was alarming. During the pandemic, I was on the school board in Chesterfield County, and so navigating the return to in-person learning. And I was a strong supporter, which I was a bit of an outlier, especially since I was very much in the public space, for a progressive that said kids need to be in school. Like, you know, I'm looking at that abroad connection. Like everyone I knew in other countries were like, of course, kids have to be back in school. You know, there's all this literature. There's like a whole, you know, you call them NGOs instead of nonprofits, like usually in the international space. And so there are whole NGOs that are devoted to what happens when kids are out of school for extended periods of time. So I'm like, look, there's all this literature, but there's no American literature, right? It was funny. I remember, you know, the person with the last degrees telling me, you know, Kathryn, you know, the WHO isn't exactly reputable, or, you know, just that everyone had an excuse for why I just wasn't seeing it. And to me, it was just like, but everyone's doing this. And then at some point I like, where are the community health workers? Where are the trusted messengers that can help me do this? Because I knew there would be, you know, vaccine hesitancy, for example. And I knew that from my, you know, personal experience. You know, when it's not something I share very often because then people are going to think I'm some crazy person. But when a system has earned your distrust and you were already maybe, you know, my mom's people were very, you know, do-it-yourself people. They, you know, came over and, you know, they're farmers and farming not great land because that's the land that was left, and gave birth at home, right? And so, but people didn't understand that there was going to be this hesitancy, right? And so I'm in this system where, okay, I need these trusted, and we really had to wait for the federal funding, right? With the federal funding, and Reich was an exception because Danny Vula and I, you know, was like, who is this? Anyone doing this? And he had, but other than, you know, I didn't find, you know, anyone who had done really like formal working with community health workers until the pandemic and this federal money starts coming in. So I think that's when I realized like how far behind we were. You know, I think, you know, Virginia has this saying that's like, as Virginia goes, so goes the nation. So I'm thinking, but we don't even really use community health workers. Like, whoa. And then I discovered, you know, the public health infrastructure, and how, you know, I could rattle off all the data about, you know, schools, because that was, you know, the area that I was playing in at the moment. But then I learned that the same problem, you know, like teachers quitting their job within the first 5 years, that it was even worse for public health, right? And so, yeah, I think having had the experience abroad gave me an understanding for what's possible, and in the maternal health space, right? That after you give birth, there is incredible support, right?
Yes, much longer maternity leave in Europe.
And so it's like I had this, like, you know, from my mom's culture, and then I moved to Mali in West Africa, and they were saying the same thing that my grandmother and my mom were saying. And then, you know, I come back to the U.S. and it's different here. And I remember my good friend, who my eldest is named after, came over from Mali, and she brought her daughter with her, and we're getting ready. She wanted to see an American grocery store, so I'm like, great, okay, I need to go grocery shopping anyways. And she comes downstairs, she's ready to go, and I'm like, where's Isata? I have Kadi on my hip, and Kadi said, so when's the neighbor coming over, right? Like, I don't understand your question. Or we're gonna drop them at someone's. We'll drop them at the neighbor's, right? And I went, no, we're taking them with us. And then, so what about when you like go to the bank? Yeah, we take them with us. And what about when you go to the doctor, right? Like, doctor, certainly you don't go to the doctor with your child. And I know also they go with us to the doctor. Like, that's how it works in America if you can't afford childcare. And she said, Kathryn, you should have told me. I would not have brought Isata with me. And it's so being able to, and then again, the policy journey. I'm glad that you didn't give all the money away, because it takes, you know, years. I have to temper my enthusiasm, because now that I see this incredible moment of change, and also it's going to take, you know, I want Virginia to transition to the midwifery model of care. Yeah. I'd like to say 10 years, like 20. But having, you know, been in spaces, you know, knowing that it was different when my mom was growing up in her Polish immigrant community in northern Wisconsin, knowing that in Mali, you know, these cultural values of taking care of community and providing that warm touch, the community health workers that can translate the cultural differences, you know, midwives. You know, I've been trying to wrap my brain around this whole concept of home visiting, and it's like a title. To me, a home visit is how you make sure your people are safe, right?
Mm-hmm.
Like, it's a part of what you do. So community health workers do home visits, and midwives do home visits. I'm like, home visitors do home visits? I don't really understand that. And that's how you can get the cultural information, right? So it doesn't have to be you, but your community health worker will say, you know, in this culture, they're going to tell you they're fine, but they're actually not, right? And they're going to tell you that they're eating well, but I checked their fridge, because that's, you know, a midwife always says home visit. You always check the fridge, what's in the fridge, and the fridge is empty, right? So then you know that you need to connect them to more resources than you thought.
The understanding that change will take a really long time. So the idea that the grants are more multi-year grants. I mean, a year is really maybe not long enough to do some of the things that you need to do, or to help somebody get through a study to fund an expansion, to then build an expansion to whatever it might be, like how long those things sometimes might take to make the right decision. And so giving somebody a grant that lasts longer so they have more time to plan and to have the right engagement with their community makes a lot of sense. So they're not just constantly writing the proposal to win it the next year, and suddenly then you're just writing the proposal again. And you're kind of like, you're stuck in a cycle of process rather than like impact.
That's how we got to the public health system that we have. It's mostly grant driven, and it changes every year. And it's, oh, let's do tobacco cessation. Oh, let's do, it's crazy. I had no idea that like you have public health systems that 90% imagine is funded by grants. So it just blows my mind. No wonder we're not very healthy.
I think between what Kathryn has said and what Yvonne does, I think the answer is here. I mean, it's we need to have people. I don't mean to be redundant, but we need to have people on the ground who, like, from midwives to doulas to community health workers, and a front door that's the whole person. You know, and that's what's missing. It's like, and even like the people on the ground could point toward a front door that will be welcoming, and I think that would solve our issue.
I'm curious about what have you heard, or what sort of is an approach that you take for helping people with adjusting their lifestyle choices, or combating sort of this systematic issues that they run into in terms of getting healthy food, or getting to PT if they needed to have it, or whatever it might be. Kind of how do you approach helping people find those resources when their barriers to health are there?
Well, first, you know, part of being an integrated practice is that all the providers across disciplines share one clinical history form. So when a patient comes in, everybody's getting the same information, and part of that for us is the social determinants of health. And so whichever door you're coming in, whoever you're seeing, we have some sense of what you're struggling with, you know, assuming they filled out the form, which is always another issue. But anyway, and so the whole premise of lifestyle medicine is that health is co-authored. You have a partnership with the person, and you are meeting them where they are in their life, in their environment. So whether it's housing insecurity or food insecurity or domestic violence or what have you, we have to know that before you get a lecture on how you should be eating, you know? That's not, the patient education has to be in the context of the person's environment. And so we're trying to understand the environment, and it's not just the form they fill out, it's the conversation that you have with the eye contact, because we use AI to help with the note taking. And then it's preferences. you can, even if you can access this said resource, if you don't like that kind of food, you're not going to eat it. And if you don't feel safe taking a walk, you're not going to take a walk. You know, you have to figure out all those preferences, how this struggling mother can't accommodate. It's too much for her to even think about fixing this separate meal because nobody else in the family is going to eat it, and she's got to cook this. You know, I mean, there's so many factors, and so that's part of it is understand the person in their environment. Here's our community resource list. Which one can you access? What's your insurance? What's your bus line? You know, like so many things that we have to consider.
Who has later hours?
Yeah,
can't get off of work.
Yeah. And it's been astonishing how many barriers people have just psychologically to simple things. And so some of our providers will take a walk with people. Some of them and around the parking lot, see, this is movement. You can do this while we have this session, and teaching them about how to grocery shop and how to read a label, you know, those kinds of things. So, I mean, there's just so many roads to go down in helping get people to the resources they need. But yeah, so we're constantly updating our list of what's out there and how we can connect people to it. But so work in progress.
I think earlier somebody mentioned the idea that you could just walk the person to, you know, walk them across the hallway. Here, go talk to this person. Or we did work, Andy could share a little bit about out at UVA with some of the students in this care and support services team. So a student, when they're in crisis, the office facility that we did is like the first stop. And then they take the student and walk them, whether they needed to go to therapy services, whether they're food insecure and they need to go to the pantry, whether it's more financial assistance related and they're worried they can't pay that tuition bill, they're going to go here. So it's like this first line of defense. It's, you know, getting you walking there. Because even if somebody gives me a pamphlet and then, or you sign up on a website to try to find access, until somebody tells me I used Joan, go talk to Joan.
Those warm handoffs.
That's where I'm going. I think that breaks a little bit of that barrier. Any other thoughts or questions as we're kind of wrapping up? I think we've touched on a lot of really good topics and some really consistent themes, I think, throughout the organizations. And there's a lot of optimism here in Virginia and people really trying to bring more access and bring more holistic care.
Just that everybody has to get engaged in the policy work because ultimately, you know, like I'm sure I could ask you the list of things that you need to really take your work to the next level, right? And obviously your organization funds groups that do that. But when you translate that, so like my favorite bill that we did last year was the one, or the last session in January, was the one that would allow nurse midwives and certified midwives and pediatric nurse practitioners to provide general service, to provide nursery care and general service hospitals to prevent rural labor and delivery closing. So you translate like the on-the-ground connection that I have because I was a midwife, and it started with a phone call that said, like, Kathryn, I cannot, like, I'm gonna quit. Like, I cannot handle this. I'm gonna never break down. You know, you imagine waking up in five days. The hospital was going to close their labor delivery for 5 days, and if you were a certified professional midwife, you had to risk going to jail because the closest hospital is in North Carolina. So midwife could go to jail because, and this is happening in North Carolina. Midwives are going to, it's crazy, and also the client risks that they're on Medicaid, and the hospital had said, well, if it's an emergency, we'll take. Well, you don't want to transfer an emergency when you're in labor and delivery, right? And so, you know, at Virginia Interfaith, right, we're able to get the legislators, you know, explain the issue, figure out the, you know, what is the problem, you know, get the code language that will, you know, fix the problem. But then what really, like, this everybody engaging in this work, it was a doula from the Danville area, so impacted by the hospital closure, that woke up at 3 a.m. and traveled to, and it was my midwife friend who had made the connection to the doula, and spoke in front of the General Assembly. Right, that led to a unanimous bill. Right, like it takes all of us. It wasn't just one person, and when ordinary people engage in this work, I mean, she just, unanimous bill, not one vote against, and that's unique because when you're in the healthcare space, it can become like a hospital insurance doctor conversation, and the only way to break that, which is ultimately why I'm at Virginia Interfaith, is this is not a doctor hospital, this is about moms and babies.
Yes, like where's the patient in that little circle?
And then it was after Roche spoke, the ER doc lobbyist, or she might have, one of the lobbyists said, "We support," because right? I mean, it was just so, and I was like, "You did that, right?" Like, because they stay neutral. They don't say we support, right? Because they have the unwritten rules. We can make you neutral, but we have to be very careful of our peace that we negotiated. So, it's people can, right? That can,
I think you said another key word, which is prevent. And prevention seems to be a value that policymakers and insurance payers do not understand. They don't seem to understand anything that isn't on fire. And so they don't want to fund it unless it's an emergency. It seems so hard to get people to understand the value of a doula, of education, of all the other things.
Go to primary care to get covered rather than going to the ER to get covered.
Yes, that like what
$10 versus
$200.
$200.
I don't understand.
And the data is there.
It's so clear. You're going to save so much money, insurance companies, if you just.
We're taking the risk.
Right.
We're taking the bet that they won't.
I'm feeling hopeful listening, being in this conversation. I tell you what gives me concern right now is, are we in our own little bubble? Because I hear so much about people not trusting poor people, not trusting Black or brown people. It's like it feels as though this is a game of gotcha, and so that's why we need to change our financial, we need to pull money back because it's being abused and so much fraud.
Yes.
We know that that's not true. But I don't know how to. I think you said it. The only way to break that is to have people going before policymakers. You're looking at me. This is my story. I'm not lying. Maybe that's how we soften hearts. But I have to admit, I just some days just feel like people just are determined to believe that we're all making this up and we're helping bad people, illegal people. They're human beings who we should hope they stay alive. I don't know. It's just
like a lack of empathy.
Oh, and that's a dirty word, empathy.
I think we're only in our bubble if we stay in our bubble. I think the hardest thing for I guess more progressive folks to do is to acknowledge that they are also othering. If that's the conservative person over there, I've othered them. Like I've given up. One of my favorite stories is the work on the bias reduction bill, which is going to pass in 2026, that we do. And it is co-patroned with Senator Locke by Senator Head, who is a white rural Republican, right? And he will say, when a white rural Republican, very conservative from Southwest Virginia, Bonnetour County, partners with a Black liberal Eastern Hampton Roads area senator, like, you should listen to us. Like, that is so powerful. He's telling his people, listen. And you mentioned silos. So he was able to do that because he works in the healthcare sector, right? He owns a nursing home. It might be multiple, but he is in the nursing home business. And during someone had told me, because I'm off, I go, right? So I'm on Monday morning, I'm waking up and I'm driving 6 hours to Cedar Bluff. Like, I'm always on the ground, hear a lot of stories. And one story that I heard about in her head was during the pandemic. I guess they think it, I might not have all the details. You would get extra federal funding if all of your staff were vaccinated. And his nursing home staff are majority African-American women. And in that moment of, wait a minute, I as a white guy and not understanding the full history of vaccine hesitancy, like, I am not the appropriate messenger here, right? And so he found a trusted messenger to speak to his staff. And that then led to, right, and you can then the leap of, oh wait, I had a bias, right? To me, it's so natural that then he could, champion this bell, because, he realized that, he didn't understand, and he sought help.
That person was the community health worker.
Yeah.
They were the bridge that had the right background to be reputable to those people. We go into a lot of projects, and it goes back to, in this whole series, is us in no way saying that we have the answers, but it's us wanting to have the conversation so we can learn more, so we can design better, and so we can educate our clients on, well, let's go through this step and engage with these people, or ask them the questions, prevent these others, or prevent the assumptions of why somebody is going to feel more comfortable one way or the other.
I realize that I've been an idealist, but 9 times out of 10,
Hey, that's better.
And I don't know, if midwives can do it, anyone can do it.
It's lovely. Any other closing remarks? Again, we appreciate everybody's time today. Just kind of doing a nice wrap up, having you all meet each other. Again, we'll share copies of all of this. You can see them before they go out, but it's really just sort of an education campaign and to bring more people into the conversations. I love that we connected some of our past clients together here today. So thank you.
Thank you so
Thank you.
much.
Thank you all.
Thank you.